It's wonderful symposium, and I'm really overwhelmed by the more exciting debates. So, anyways, I have to say. Okay, so today, I'm going to talk about from the standpoint of head and neck surgeons. So, first, I will briefly explain the current trend for the treatment of advanced head and neck cancer, and then I will explain the algorithms we are using for the treatment of head and neck and esophageal cancer. For head and neck, we are using a little bit unique strategies that is called chemo selection. And as already mentioned by Dr. Higashi and Dr. Towa, we are using a Japanese guideline for the treatment of esophageal cancer. So that means when we treat synchronous cancers, we have to find a way to merge these two algorithms. So through our experiences, we are now getting a prototype of algorithm. So I'm going to explain how to apply this algorithm to case 2. So during the last decade, the mainstay of the treatment for advanced head and neck cancer has shifted from radical surgery to preserving those intensified strategies, exemplified by this study. So this is an LTOG 911 protocol published in the Journal of Medicine in 2003. So in this study, advanced laryngeal cancer were treated with 3 different modalities. Among them, CCLT regimen in which cisplatin was administered like this, demonstrated unexpectedly good for survival and laryngeal preservation. Thus, this heavy regimen became world standard for the treatment of other advanced head and neck cancer. Meanwhile, in 2007, another type of regimen, a tax protocol, was published also in the New England Journal of Medicine. In this algorithm, after randomization, patients are treated with either TPF, 3 cycles of TPF or PF, and then go to the sequential CCLT. And this very strong regimen almost demonstrated unexpectedly high survival in laryngeal preservation, especially in TPF arm. But when I first read this paper, I thought, are you crazy? So, no Japanese patient can tolerate this heavy regimen. But it is now used worldwide, including Japan. However, as expected, recent long-term results indicate that these protocols are associated with severe late toxicities like loss of respiratory and swallowing function, and treatment-related is probably caused by aspiration pneumonia. So what we learned from these studies, organ preservation achieved by these strong protocols does not mean functional preservation. So now we have to seriously think about how to optimize treatment intensity, which seems to have this upper limit of human tolerance. So as pointed in recent reviews like this. So on the other hand, since 1972, we have very old history. We have been used moderate intensity CCLT as a selection tool for organ preservation, which we call chemo selection strategies. In brief, we evaluated tumor response at 30 to 40 rate, and then the responder, we call chemo selected patient, goes to the organ preservation and underwent a planned neck dissection. On the other hand, for responder, non-chemo selected patient go to surgical arm. There are 2 basic principles in this strategy. So first, to measure biological aggressiveness of each tumor by induction chemotherapy, and to balance the therapeutic ratio by taking full advantage of radical surgery and moderate intensity therapy. So I will show you a recent result of 55 advanced high-pharyngeal carcinoma treated with this protocol, recently published in Head and Neck. So according to this algorithm, 27, almost half patient was chemo selected and go to organ preservation now. And while the 28 was unfortunately non-chemo selected, and so underwent injected, although a certain patient refused operation. This is a result of overall survival and disease-specific survival. As you can see, so quite favorable survival was obtained from this treatment for the result of advanced hypopharyngeal carcinomas. It's better than the LTOG attacks. We then looked at the patient survival according to the chemoradio selected on that. As you can see, chemoradio selected patient means so they avoided laryngectomy, demonstrate better survival than those who underwent laryngectomy. So in addition, so chemoradio selected patient have less treatment-related deaths. So these data indicate biological aggressiveness of each tumor is to be segregated by chemoradio selection. So this is a slide of functional laryngeal preservation. So as you can see, chemoradio selected patient demonstrated really good laryngeal preservation. But however, so overall the laryngeal preservation remained like this. So not so that improvements are required. So then we then examine hazards of radical surgery, means laryngectomy. It can contribute to patient survival. So as you can see, so T3, T4 is not feasible. Laryngeal preservation is not feasible in T3, T4. However, their survival, overall survival is similar to T1, T3. So probably indicating surgery can improve the survival of advanced T. However, at the same time, we found that for T4 hypopharynx laryngeal preservation is not feasible, so I think that initial surgery might be a better option for T4 cases. So in conclusion, so chemoradio selection can be used useful platform for the treatment of head and neck cancer, achieving treatment intensity and favorable survival. However, to further improve our result, in particular the low laryngeal preservation rates, we have to move the result for this for this direction. So to this aim, so it's apparently if we can set more chemoselect, we can chemoselect more patient, probably we can get a better survival. So for this purpose, so we changed our radio selection region a little bit. So now we are doing bolus cisplatin, 80 milligram per scale day, and we intensify the CCLT and in turn relax the evaluation criteria. So for the previous protocol, we have only CL patient go to the other patient. Now we good PL patient also goes to the preservation plan. So consequently, this is a current treatment algorithm for carcinoma, laryngeal, and hypopharynx. For T4, we now surgery. However, so as a patient will be treated with induction, CCLT, as well as platinum, and then we evaluate, then decide the further treatment. From here, I intend the main part of my talk. So as I explained, Dr. Higashiro, we treat this for the patient according to this Japanese algorithm. So, however, the most challenging part of this when you incorporate two algorithms, the treatment of stage 1, 2, 3 esophagus and advanced head and neck makes serious problem. So I'm going to focus on how to treat these populations. So now what we have to do is how to merge this algorithm, esophagus and advanced head and neck. So in daily practices, we have accumulated our experiences and have learned that it is not easy to make a fit in all algorithms, right? So, however, on this good occasion of the symposium, I try to make more order-made algorithms by combining different stage of each cancer one by one. So this is pattern 1. I combined stage 1 ESO and T4 hyperpharynx. In this case, probably one stage surgery, including pharyngeal total esophageal plus gastric tube, might be a good option, I think. This is pattern 2, combination of stage 1 ESO and stage 3, 4, excluding T4 hyperpharynx. In this case, both algorithms first go to CCRP, So, however, this leads to a large radiation field. So we have to carefully think about what is the optimal regimen for CCLT. In the Japan esophageal guidelines, the standard regimen is for this type of esophageal cancer is PF, 70 and 700 milligram dose plus week. And the esophageal team and also doctor all prefer this regimen, but I'm a little bit skeptical about this might be too heavy. So we checked this types of CCLT is really feasible. So far, I found that so far 5 patients underwent FP CCLT regimen. 3 were treated with standard FP 7700, and on the other hand, the 2 patients underwent 10% reduced dose of FP regimen. So as you can see, so 1 patient treated with standard FP developed grade 3 DIC and grade 4 thrombocytopenia, and it's a very long sprint before we can resume the treatment. So if you think this is a dose limiting toxicities, 10% reduced FP might be a recommended dose. So now patterns will become like this. If the head and neck tumors are selected after CCLT, the patient undergo additional CCLT and receive only neck dissection, avoiding both esophagectomy and laryngectomy. When the head and neck tumor non-chemosoluble type is selected, the patient proceeds to surgery alone. In this case, if the head and neck tumor is larynx or larynx non-preservable pharynx, one stage operation, pharyngeal total esophagectomy is inevitable. However, if the tumor is laryngeal preservable or pharynx, probably 2-stage surgery might be chosen aiming at laryngeal preservation. So pattern 3 is a combination of advanced cases. This is also relatively simple, and following induction chemotherapy 2 cycles, and the 1-stage operation is likely to be the reduction. So this is the last combination, stage 2-3 ESO and the stage 3-4 head and neck. In this pattern, esophagectomy is mandatory after induction chemo according to the Japanese guideline. So while head and neck surgery can be spared if chemo is selected. So at first, FP is at the lead step, but unlike pattern 2, only head and neck field is irradiated, resulting in FP CCLT. Then after evaluation of head and neck tumor, responder receive further FP CCLT up to 70 grade. Through this regimen, esophagus received 2 induction chemotherapy. Then they go. Then after evaluation, okay. Through this, then they undergo partial esophagectomy plus planned neck dissection. When the head and neck tumor doesn't chemo selected, when the patient treated with partial esophagectomy plus head and neck surgery, with or without laryngectomy, depending on the primary tumor site, as I explained in pattern 2. So, however, in this case, the handling of second induction chemo are quite difficult. So now I can somehow complete the making of algorithm, and I want to think about how to treat case 2. For this case, pattern 4 is applicable. However, I think one important information is missing, that is in this case HPV positive or not negative. So as you know, so HPV positive or carcinoma is a hot topic in the field of head and neck cancer. So it is now well known that relatively high incidence of carcinomas are HPV positive, and unlike the conventional HPV negative carcinoma feature cross-mediated tobacco drinking and greater nets in here. So HPV positive oropharyngeal carcinoma are highly sensitive to chemo radiation and thereby good candidate for their organ preservation. This is a result of recent Japanese data. So as you can see, a majority of HPV positive advanced oropharyngeal cancer are cured by only CCLP. So in an institute, HPV status is checked for all oropharyngeal cancer. This slide shows the representative HPV positive T4 oropharyngeal cancers cured by CCLP alone in the institute. At 40 grade, the body tumor both responded very well, and the CR was achieved after 70 days CCLP. So if this case is HPV positive, I don't know, he's positive or not, but the case might be chemorally selected by CCLP, and then organ preservation might be feasible. However, if not chemorally selected, using total laryngectomy is mandatory for this case. The answer is no, so no. My answer is no. So I'll explain the reasons to the representative case. This is a really advanced oropharyngeal carcinoma lying in the base of them in 43-year-old female. She was young and strongly wanted laryngeal preservation, and we tried laryngeal preserved surgery. So this is a picture of the surgery. So after push-through oropharyngectomy, after push-through tumor resection, including almost all the base of the tongue, we reconstructed the defect with airway encephalo. The most important part of point is to make a larger base of 10 than the original size. Also, it's very difficult to explain what is the appropriate size. So, anyway, probably due to this a little bit overly reconstructed base of 10, good speech and swallowing function obtained, and she could go back to the job. So, the patient is, this patient, case 2 is young, and therefore we expect that laryngeal preservation surgery might be worthy of a try. For this case, on condition that tumor shrinkage will be achieved by CCLP. So now considering this finding, so let's think about the possible treatment course for case 2. Oropharynx will be, only oropharynx will be irradiated. Then, if chemorally selected, he will receive esophageal and round dissection, avoiding pharyngectomy. So, when non-chemorally selected, that considerable tumor shrinkage will be obtained, subtotal esophagectomy and larynx preserved pharyngectomy will be considered. So, otherwise, once this subtotal esophagectomy and laryngopharyngeal will be inevitable. So this is a summary of the slide. So I made some prototypes. So it's obvious that validation and sophistication is required through the accumulation of cases, and especially so long-term toxicity for the case with larynx. The functional analysis might be important thing to do. So thank you for your attention.